بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is one of the hard topics in the head and neck imaging, and I will try to simplify it as much as I can. It will concern with imaging of the skull base. As you all know that this is one of the important areas in the head and neck imaging because the skull base is considered the pathway for many of the structures going to the intracranium or outside the cranium. And the skull base is usually divided into three parts: the anterior skull base, the middle, and the posterior skull base. And we have three parts of this topic, and I will handle in each part one of the areas of the skull base. And now we'll deal with the anterior skull base. You all know that we have many imaging modalities that can fit for evaluation of skull base lesions, including the X-rays, the CT, MRI, angiography, whether conventional uh, or through imaging, and also PET scan may have some of the benefits in this area. CT and MRI are the main diagnostic modalities used for evaluation of the skull base, and the CT is usually helpful in evaluation of the bony anatomy of the skull base as well as the skull base foramina, detecting the cortical margins and the neurovascular foramina, detecting fibro-osseous skull base lesions, and this will be shown during the lecture. The evaluation of fibrous dysplasia and other tumors of fibrous origin are better assessed by CT than MRI. Also, CT is more helpful, of course, than plain X-ray and MRI in detection of calcium as well as the detection of bone sclerosis. One of the best values for CT is the assessment of fractures and post-traumatic CSF leak. Then MRI is very important in evaluation of dural and leptomeningeal invasion by skull-based tumors and also the intracranial extension of these tumors. One of the main values also is of MRI is to evaluate the extension of the tumor along the nerve roots, perineural, perivascular spread, as well as evaluation of bone marrow involvement. Usually, we use the T1 and T2 weighted images supported by the fat suppression technique, and the slice thickness is in the range of 3 millimeter. The stir images, which are which are helpful in fat suppression to see some of the bone marrow lesions in this area. And diffusion weighted images are extremely important in evaluation of the head and neck in general and the skull base lesions in particular. The gradient images or T2 star images can show the blooming effect in cases where calcium is present and also hemorrhage or hemosiderin, and sometimes melanin if present. Then, what are the important roles of imaging in this particular area? Number one is the detection of the lesion and to show its accurate extensions, to show accurately its extensions. Then differentiation between benign and malignant lesions, and looking for the possible resectability of the tumor, including invasion of the important structures like the orbit, extension along the nerve roots, or invasion of the cavernous sinus and major vascular structures, dural and parenchymal invasion. Then the dural invasion is one of the major tasks of MRI in evaluation of skull-base lesions, and this will significantly decreases the 5-year survival rate. The main diagnostic sign of dural invasion is the presence of nodular or linear dural thickening, which is thicker than 5 millimeter in thickness. And you can see here, this is a calvareal lesion which has invaded the dura, diagnosed by considerable thickening of the dura and enhancement. And if there is a dural enhancement of less than 5 millimeter thickness, this may not represent a dural invasion, but maybe reaction to the contact of the tumor to the dura. The perineural spread is well known in this particular lesion, which is the adenoid cystic carcinoma, but can occur in many of other tumors. This is the most common lesion to spread by along the nerve roots, but squamous cell carcinoma, melanoma, lymphoma, breast carcinoma, rhabdomyosarcoma, neuroblastoma, and many other tumors can spread by nerve roots. The most commonly affected nerve root is the fifth, the trigeminal nerve, but can occur along any of the well-known cranial nerves. This will lead to invasion of the cavernous sinus, invasion of the cranial nerve itself, and invasion of the skull base, and it is also associated with poor prognosis. Then we classified the skull-based diseases into congenital, inflammatory, traumatic, and neoplastic. Congenital lesions like nasal glioma, nasal dermoid, encephalocele, meningocele, and racemic cleft cyst. Inflammation like pyogenic fungus and tuberculous infection. Non-infective like sarcoidosis and Wagner granulomatosis, as well as mucoceles. Traumatic fractures and CSF leaks, as well as the neoplastic lesions. These tumors can occur anywhere in the skull base, in the anterior skull base, or the middle or the posterior one. And we will also show examples of these lesions whenever we handle any of the three components of the skull base. Fibrous dysplasia, disease, chondrosarcoma, squamous and adenocarcinoma, rhabdomyosarcoma, lymphoma, meningioma, metastases, and the plasmacytoma, its counterpart, the multiple myeloma. Then these are the anterior skull-based lesions that we are going to discuss, including the encephalocele, and this is one of the important issues, which is known as arrested pneumatization, fracture and CSF leaks, and then some of the paranasal sinus lesions that can involve the anterior skull base, like mucoceles, fungal sinusitis, inverted papilloma, carcinoma, lymphoma, sarcoma, and the metastatic deposits. Also, one of the well-known tumors of the anterior skull base is the eosinogenic neuroblastoma or olfactory neuroblastoma, and olfactory groove meningioma and skull base deposits. Also, we'll have some words about fibrous dysplasia and Paget's disease. Sorry. Then the anterior skull base is formed by the orbital plate of the frontal bone, and this one, and the cribriform plate of ethmoids, as well as the crista galli and in the midline, and posteriorly by the lesser wing of the sphenoid, this green one, as well as part of the greater wing of the sphenoid bone. The frontal and ethmoid sinuses, as well as the nasal cavity and orbits, are below the anterior skull base. The frontal lobe meninges are above the anterior skull base. And these are the images in the coronal and axial planes showing some of the details of the anterior skull base. One of the important structures is the cribriform plate of ethmoids, this very fine horizontal plate. And this is, of course, the crista galli, and this is the depression for the olfactory bulb or the olfactory groove. And in this axial image, you can see part of the frontal sinuses, and this arrow points to the foramen cecum, which contains nothing and is usually obliterated by fibrous tissue. Then this is what we call the lateral lamella, which is part of the anterior skull base. As I have mentioned, I said that this is the cribriform plate of ethmoids, and this is the crista galli. Then this is what we call the lateral lamella, which is the junction between the cribriform plate of ethmoids and another structure which is present here known as the fovea ethmoidalis. Then the lateral lamella is the intermediate zone between the cribriform plate and the fovea ethmoidalis. And the depth of this area is measured by Keros and is divided into three types. Type 1, where the depth of the olfactory fossa is less than 3 millimeter in height, and type 2 is from 4 to 7 millimeter, and type 3 is from 8 to 16 millimeter. This type 3 is the most vulnerable to a iatrogenic injury during endoscopic surgery for the paranasal sinuses. And this is type 1 Kear's classification of the depth of the olfactory fossa, and this is type 2, and this is type 3. Then what are the communication pathways between the intra and the extracranial areas? Number one, the foramen cecum, which may contain an emissary vein and usually is obliterated by fibrous tissue. The foramina of the cribriform plate of ethmoids, which transmits the olfactory fibers, and the optic nerve canal, which transmits the optic nerve as well as the ophthalmic artery. And this is once more the anatomic details of the anterior skull base. This is the cribriform plate of ethmoids. This is the olfactory fossa, and this is the lateral lamella, and this is the fovea ethmoidalis, and this is the bony nasal septum, as you all know, and this is the middle turbinate or the vertical plate of the middle turbinate. Then in the sagittal image, you can see clearly this is the frontal sinus, and this is the cribriform plate of ethmoids. This is the sphenoid sinus, and this is the dorsum celli, and this is the clivus. We'll discuss this in the middle cranial fossa, of course, inshallah. Then the first lesion in this part of the skull base is encephalocele, and encephalocele means that there is a herniation of the meninges and CSF as well as maybe part of the brain tissue through a defect in the anterior skull base. This encephalocele may contain or may not contain brain tissue, and it is usually communicated directly to the intracranial space, and the contents may show high signal because of the CSF as well as some of the herniated brain tissue, which may be disorganized brain tissue. Nasal encephalocele are known as, or encephaloceles in general, are either frontoethmoidal or basal. The frontoethmoidal encephaloceles occur at the root of the nose, and the basal meningocele occur in or posterior to the cribriform plate of ethmoids. And this is the appearance of a frontoethmoidal encephalocele, which is herniation of the brain tissue through a defect in the anterior part of the cribriform plate of ethmoids. And this coronal CT, and you can see an opacity here with some defective area in the region of the fovea ethmoidalis, and the coronal MRI T1 and T2 can demonstrate clearly the presence of brain tissue as well as some of the CSF in the encephalocele. And this is axial CT images and coronal T1 weighted MR image showing the defect in the anterior part of the cribriform plate of ethmoids, the meningeal sac containing brain tissue, and also you can appreciate the presence of brain tissue in this encephalocele. Encephalocele can be evaluated by CT and MRI. CT will show the bony defect, MRI will show the contents. If there is only CSF or this CSF is associated with some of the disorganized brain tissue. And sometimes we can have the 3D reformatted images by CT for accurate evaluation of the bone defect. Some of the associated anomalies with encephalocele include agenesis of the corpus callosum, hydrocephalus, and holoprosencephalus. This is what we call the basal encephalocele, where there is herniation of CSF through the posterior part of the cribriform plate of ethmoids, and through the defect also the pituitary stalk as well as the pituitary gland are also seen herniating through the defect. And this issue, which is known as areas of arrested pneumatization, involves typically the area of the basi-sphenoid. And this is well known by the name don't touch lesion. This is not a lesion actually, it is just non-pneumatization of an area which is intimately related to the sphenoid sinus. Then this area on CT can be easily diagnosed, but on MRI it may be mistaken for a tumor. And pneumatization of the skull base and the paranasal sinuses start at the age of 4 months, and it continue to the young adulthood. First, the red bone marrow is replaced by fatty marrow before pneumatization. Then fatty marrow is invaded by epithelial cells from the respiratory mucosa, and then pneumatization will occur. And if you see by CT, and he got a, this is very important criteria, a non-expanding lesion, internal curvilinear calcification, and sclerotic margin. On MRI, the presence of fat within the lesion signifies that this is not a tumor. Absence of any mass effect and no expansion. This lesion is not an expanding lesion. Also, you can see the basal skull foramina, which are not displaced or disrupted. And this is what we mean by arrested pneumatization. This is the normal pneumatization of the sphenoid sinus, and here you can see that good part of the sphenoid sinus, especially the left one, is non-pneumatized with an area of fat and bone marrow trabeculae replacing the air. But you can easily appreciate that the Vatian canal as well as the foramen rotundum are intact and not displaced or eroded by the lesion. This is the usual appearance of arrested pneumatization of the skull base by CT. There is bone marrow in the along the left side of the sphenoid sinus, but this is the normal appearance if complete pneumatization occurred. And here you can see arrested pneumatization, and you see this is the greater wing, the pterygoid blades, and also the left side to the sphenoid sinus. There is an area of loss of pneumatization compared to the right one. Another example showing the arrested pneumatization to the left side of the sphenoid sinus, with only this part is pneumatized. This is the normal appearance by CT. But look by MRI, if you look carefully here in this axial T1 post contrast and axial T2 weighted images, and you can see a lesion which is of low signal in the T1 and high signal in the T2, and there is no significant enhancement in the post-contrast images. Many times you may feel that this is a skull base tumor or a nasopharyngeal mass invading in the skull base or something like this. But if you go to the CT scan, and you can solve the problem very easily, where you can see normal bone distribution and trabecally intact cortical bone, no evidence of destruction or erosion. And by MRI, this may be included in the differential diagnosis of arrested pneumatization, fibrous dysplasia, ossifying fibroma, chondrosarcoma, osteomyelitis, chordoma, and bone metastasis. Then, in contrast to arrested pneumatization, all these conditions lack the presence of internal fat within the lesion and usually show signs of mass effect on the adjacent structures. Then we came to the fibrous dysplasia, which I think is well known for all of you. This is a developmental abnormality, affects any bone in the body, and it has two main types: the monostotic type, which presents by a single lesion, and the polystotic type, which affects many of the bones in the body. Head and neck involvement by fibrous dysplasia is about 10 to 25% in monostotic form, and in 50% in patients with polystotic fibrous dysplasia. The major diagnostic imaging finding of fibrous dysplasia is bone expansion and the ground glass appearance. There is no bone destruction, no extraosseous soft tissue component. You should remember that this lesion will show significant tracer uptake in bone scan because these lesions are metabolically active. By MRI, it is advised that in cases of fibroosseous lesions, please don't try to diagnose these lesions by MRI alone, otherwise you will make some mistakes. Here you see a very big lesion in the skull base and the calvarium on the right side, which may sometimes mimic a tumor. The fibrous tissue usually show significant contrast enhancement, and this will be evident on MRI, of course. In the T2 weighted images, most of the lesions may show low signal, as you can see here, but some of the lesions, due to the presence of cystic changes, will show high T2 signal. You should remember that fibrous dysplasia is a metabolically active lesion, and the sarcomatous transformation is considered rare, representing less than 0.5% of the cases, and is usually transformed into osteosarcoma. These are two images for a fibrous dysplasia of the anterior cranial fossa as well as the temporal bone, squamous part of the temporal bone, lateral orbital wall. You see the difference between MRI and CT. The lesion is clearly demonstrated in the CT images, and may be mistaken here for many other possibilities. This is extensive fibrous dysplasia of the skull base, affecting the anterior and middle and also the posterior skull base, with encroachment on the orbital cavities as well as the ethmoidal air cells, clearly demonstrated by CT. Another example of skull base fibrous dysplasia affecting the region of the sphenoid sinus, the pituitary fossa, as well as the posterior ethmoids. And this is a localized form of fibrous dysplasia involving the left maxillary antrum, part of the hard palate, as well as the alveolar margin. Then we came to the mucocele, which are inflammatory lesions of the paranasal sinuses, leading to accumulation of secretion or inflammatory material inside the sinus, which by time will expand too much to encroach on the adjacent structures. The mucoceles are common in the frontal sinuses, less common in the ethmoids, and more or less common in the maxillary antrum. This is a huge frontal mucocele by CT involving the frontal sinuses with marked expansion and thinning of the bony margins with significant encroachment on the cranial cavity as well as the orbit, of course. And here you can see the mucocele by MRI and the T1 weighted image. The contents are somewhat bright because of the mucinous content or the high proteinaceous content of the lesion. On T2 weighted images, the contents are somewhat darker, and you see the significant encroachment of the lesion on the cranial cavity. Mucoceles on MRI, sometimes they show dark signal on T2 weighted images, and they show bright signal on the T1 weighted image. After contrast injection, they will not show enhancement, or they may show only marginal contrast enhancement. And this is the appearance of a frontal mucocele with bony expansion on the right side. Frontoethmoidal mucocele by MRI, you see the expansion of the frontal sinus as well as the ethmoidal air cells encroaching on the ostium of the right maxillary of the left maxillary sinus, which accumulates secretions. An infection of the paranasal sinuses by fungus may be seen in immune competent patients and also in immune compromised patients. This is known as allergic fungal sinusitis in immune competent, invasive fungal sinusitis in immune compromised. And they said usually that invasive fungal sinusitis is diagnosed by the presence of extensive bone destruction and invasion of the surrounding structures, while the allergic fungal sinusitis has an expanding nature and less bone destructive changes. Fungal sinusitis will cause some erosion of the adjacent bones, especially the ethmoids, the orbital wall, the cribriform plate of ethmoid, with consequent extension into the nasopharynx or the pterygomaxillary space, intracranial and intraorbital extension. You remember that the fungus will appear hyperdense in the CT images even without contrast injection, and it will appear very dark on T2 weighted MRI images. This is an example of fungal sinusitis expanding and eroding the ethmoidal air cells with orbital encroachment, as well as some erosive changes in the skull base with intracranial bulge of the lesion. Another example of allergic fungal sinusitis affecting the sphenoid, the ethmoid, and the frontal sinuses with little bone erosion of the orbital roof, and some intracranial extension. And these are the imaging findings of fungal sinusitis, which include the presence of hyperdense material, and sometimes we have peripheral hypodensity, which represents the retained secretions, and also you have hypointensity on T2 in particular, weighted images. If you inject contrast, you may see peripheral marginal enhancement. The treatment of fungal sinusitis will include surgery and steroid therapy. The recurrence rate is not uncommon. This is a case of fungal sinusitis showing the classic appearance on CT images. The sinuses are little bit expanded. They contain hyperdense material. There is some erosive changes of the bony margins. And the inflammatory material has inflammatory changes has extended into have extended into the frontal sinus. Then expansion of the involved sinus, remodeling or thinning of the bony sinus wall, erosion of the sinus wall can be seen. On MRI, you may see light or slight hyperintensity of the fungus on T1 weighted images, but on T2 weighted images, you see very dark appearance of the fungus simulating air. If you inject contrast material, you may got marginal peripheral contrast enhancement of the lesions. This is the classic appearance by CT. Then we came to the trauma and CSF leaks. Skull base fractures are rare and account for about 4% in cases of severe head injury. Uh, uh, these will involve, in particular, the temporal bone as well as the cribriform plate of ethmoids. The clinical presentation is somewhat evident, and the aim of imaging is to detect the site of CSF leak. And we used to use CT after injection of intrathecal contrast material to help in detection of the site of leak. But nowadays we may use the coronal, true coronal MRI of T2 weighted image of the paranasal sinuses in order to elicit this CSF leak. Here you can see there is a defect in the cribriform plate of ethmoids on the right side, and this is the contrast material injected intrathecally, opacifying the CSF and going through the defect, and this is a sure sign of CSF rhinorrhea. And many times we used to put some cotton pledgets in the nasal fossa and look for their staining by the injected contrast material. This is one of the confirmatory findings if there is CSF rhinorrhea. And you know that rhinorrhea may be mistaken by allergic sinusitis, and you are not sure about the fluid coming from the nose if it represents the inflammatory sinus secretion or through CSF. Then here you see the defect in the cribriform plate of ethmoids, and you see this is before an intrathecal injection of the contrast. After intrathecal injection of contrast, you see the contrast material going through the defect, and you look to the nasal pledgets, so you can see that both are stained by the contrast material. It is better to have pre-contrast scans for better delineation of the defect, because many times if you injected intrathecal contrast material, the hyperdensity of the contrast may mask the site of the fracture or the defect. And here there is a suspected defect in the cribriform plate of ethmoids in the pre-contrast images. Post-contrast images showed that the contrast material is leaking through the defect, going into maybe through the nose. And using MRI in the true coronal means that you put the patient in the wrong position and you scan the head and the skull base for to demonstrate that the CSF, which is a bright signal in this T2-weighted image, will go through the defect in the anterior cranial fossa, and this may obviate the need to inject contrast material intrathecally and so on. And sometimes, if there is a defect here, there may be some of the air leaking through the defect into the cranial cavity. And here you can see these very dark signals in the CSF denoting pneumocephalus. And in this MRI, and you can see localized high signal intensity in the sphenoid sinus, which may represent sinusitis. But here you can see it very clearly, the bony defect by CT scan, and you know the cause of CSF rhinorrhea. And this just to show the value of CT and MRI. And the CT scan, you can easily appreciate that the site of the defect. And MRI, you can see CSF going through the defect. But sometimes you can see the defect also by MRI. Then we came to the anterior skull base tumors, when we have the common sinonasal malignancies, which include inverted papilloma, then this is a benign lesion, carcinoma, lymphoma, melanoma, fibrous histiocytoma, fibrosarcoma, osteosarcoma, and metastatic busts. Also, we have the olfactory neuroblastoma or ECC neuroblastoma and olfactory groove meningioma. Then you remember that we have explained in details these tumors in the sector of paranasal sinus imaging. And this is the inverted papilloma, which represents about 75% of papillomas in the paranasal sinuses. The etiology is unknown and is commonly seen in middle-aged males presenting by unilateral nasal obstruction. In cases of papilloma, you got expansion of the nasal cavity and opacification of the ipsilateral maxillary sinus, and usually there is obliteration of the ethmoidal air cells. And this is very important to differentiate this lesion from the more common antrochoanal polyp, where the sinus is expanded, not the nasal fossa, and the ethmoidal air cells are usually clear. One of the important landmarks for inverted papilloma is what's known as convoluted cerebriform pattern, where if you look to this lesion in T2-weighted image, you can see what looks like cerebral tissue. And this is one of the diagnostic landmarks of inverted papilloma. The CT features are usually non-specific, but if you refer to what I have said, you can many times spot the diagnosis of this lesion. And the soft tissue mass may show enhancement, and it occurs on the lateral nasal wall related to the middle turbinate and the maxillary ostium. Calcification and hyperostosis can be seen, which can help in the diagnosis. The convoluted cerebriform pattern is seen in about 50 to 100% of cases and is considered one of the pathognomonic findings that is not seen in other sinonasal tumors. And this is an example of inverted papilloma in the nasal fossa and the maxillary sinus. And as I have mentioned, that one of the major differential diagnoses of this lesion is the antrochoanal bulb. An inverted papilloma of the maxillary sinus showing of the nose, showing the typical cerebriform pattern, and this T2-weighted image with obstruction of the sinus ostium and retained secretions within the sinus. This lesion is histologically benign, but it may contain foci of squamous cell carcinoma. Bone destruction by pressure erosion is seen, but extensive destruction which simulate malignancy is not well known for this tumor. And the lesion, as I have mentioned, show some contrast enhancement. Then if you came to the sinonasal malignancies are more common in the maxillary sinus, less common in the ethmoids, and more or less common in the nasal cavity. The symptoms of sinonasal malignancies may simulate chronic sinusitis, but sometimes you got rhinorrhea, facial pain, paresthesia, tooth loosening, exophthalmos, epiphora, and bloody nasal discharge. The most important imaging finding of malignancies in the paranasal sinuses is bone destruction. In not expansion, but bone destruction. And you see a soft tissue mass centered to the maxillary antrum with destruction of the orbital floor, the inferior wall of the maxillary sinus, the hard palate, and part of the zygoma. And this is nicely presented in this 3D reformatted image. And it's an ethmoidal carcinoma by CT and MRI. You see a mass centered to the right ethmoids with erosion of the cribriform plate, intraorbital extension, erosion of the bony nasal septum. This is post-contrast T1 MRI image showing the tumor extension inside the orbit, as well as some of the tumor has extended intracranially as well. And sinonasal undifferentiated carcinoma involving the ethmoidal air cells with intraorbital extension on both sides, more on the right, as well as intracranial extension. During this lecture, you will see many of the lesions simulate this appearance. And to start with, and we have to consider this lesion as one of three. Number one, carcinoma. Number two, olfactory neuroblastoma. Number three, lymphoma. Number four, metastatic deposits. Then these are the common differential diagnoses for such a lesion centered to the ethmoids with some intracranial extension. And you see here sinonasal undifferentiated carcinoma involving the maxillary sinus as well as the ethmoidal air cells with significant bone destruction of the orbital wall, intraorbital extension, destruction of the nasal septum, and crossing to the opposite side of the nose, erosion of the zygoma, and extension in the subcutaneous area. And here you see the rest of the study in the axial images. In the tumor, you can appreciate very easily the aggressiveness of bone destructive changes. And as I have mentioned, if you see a lesion which is centered to the ethmoidal air cells, either unilateral or bilateral, with some extension into the adjacent orbit or both orbits, as well as intracranial extension, then the differential diagnosis will include esthesioneuroblastoma or olfactory groove neuroblastoma, squamous cell carcinoma, metastasis, and lymphoma. These are the common lesions that can be included in the differential diagnosis. Also, you may include meningioma sometimes in melanoma, and this particular tumor, which is known as sinonasal undifferentiated carcinoma. And lymphoma affects the head and affects the skull base in about 24% of the head and neck lesions. It is usually of the non-Hodgkin B cell type, and the lymphoma of the nasal cavity may be of the T cell type. Lymphoma, as I have mentioned many times before, it can involve the orbit, the nasopharynx, the jaw, any part of the head and neck can be involved by lymphoma. And also extension to the intracranium is also common. And here you can see a mass which is infiltrating the ethmoidal air cells, both maxillary sinuses, encroaching or extending inside the orbit. And as I have mentioned, that lymphoma is considered one of the four common lesions affecting this area. By CT, lymphoma will show a bulky soft tissue mass which destroys the adjacent bones, and it will show almost homogeneous post-contrast enhancement. Similar findings are also seen on MRI. And this is a lesion which is destroying the posterior ethmoids, filling the sphenoid sinus with erosion of the sinus floor as well as the left lateral wall, and it was proved to be lymphoma. But carcinoma is, of course, metastases are also considered in this area. Another example by MRI T1 weighted images showing an infiltrative lesion of the maxillary sinus, the infratemporal fossa, the nasal fossa, showing low signal in the T1 weighted images with some intraorbital extension diagnosed as lymphoma. I have mentioned that diffusion weighted images are considered very important in head and neck imaging and also in the skull base evaluation, where the tumors will show restricted diffusion, as you can see in this particular lesion affecting the nasal fossa and extending into the maxillary sinus with some bright signal in the diffusion weighted images and dark signal in the EDC map. Another example of sinonasal lymphoma affecting part of the oropharynx, the pterygoid muscles, the infratemporal fossa, the maxillary sinus, the nasal bone, and extending as well into the sphenoid sinus. The differential diagnosis of non-Hodgkin lymphoma of the skull base will include the four important lesions as carcinoma, neuroblastoma, and the metastatic disease. And this is one of the well-known tumors of the skull base or the anterior skull base, which is known as the olfactory neuroblastoma or neuroblastoma. Neuroendocrine malignancy of the neural crest, and it arises from the olfactory epithelium of the superior nasal cavity. It affects adolescents and middle-aged patients presenting by nasal obstruction and epistaxis. And this tumor is hypervascular and may bleed significantly during biopsy. There are a lot of imaging findings for this lesion, including the presence of a dumbbell-shaped mass, part intracranial, part in the ethmoids, constricted at the skull base, the upper portion intracranial, the lower portion intranasal. The waist is at the cribriform plate of ethmoids. Calcifications are well known in this tumor as well as cyst formation, especially at the border separating the tumor from the brain. And these cysts may consider one of the pathognomonic landmarks, but is not seen in every case. Then destruction of the cribriform plate of ethmoids, considerable enhancement on CT and MRI. Large tumors may have central areas of necrosis. 20% of the cases may have nodal metastasis at presentation. The treatment is by resection and radiotherapy, but the recurrence is well known. This is a highly malignant lesion and seen usually in young men, but there is another peak for this tumor at the age between 50 and 60 years. It's commonly seen in the superior lateral aspect of the nasal cavity, this area, and that's why it easily extends intracranial as well as intranasal. Then this is another example where you see the tumor in the T1 weighted image and in the T2 weighted image. It's a locally invasive tumor that affects the nasal fossa and paranasal sinuses with frequent intraorbital and intracranial extension. Obstruction of the sinus draining openings may lead to inflammatory sinusitis. Distant metastasis in about 20% of cases, and it's well known that carcinoma and lymphoma show less aggressive pattern of bone destruction compared to the olfactory neuroblastoma. In here, you see a mass in the nasal cavity and also invaded the orbit. In the sagittal image, part of the tumor is seen intracranially and part is seen in the nasal fossa and nasopharynx as well. And this is olfactory neuroblastoma in a patient with rhinorrhea and epistaxis. The tumor is big, infiltrating mainly the left side of the nose, as well as most of the orbital cavity with intracranial extension. And you see that the tumor is more or less homogeneously enhancing. This is what's known as the micro or macro cysts at the periphery or the border of the tumor between the tumor and the brain. You may got some cysts here. These cysts may be very small or maybe sizable like this. They are characteristic, but they are not seen in every case. The differential diagnosis of seen of olfactory neuroblastoma will include sinonasal carcinoma, metastasis, and lymphoma. You may include sometimes melanoma and meningioma and also granulomatous disease. But remember the four main lesions included in the differential diagnosis in this area for this appearance are the lymphoma, ethmoidal carcinoma, olfactory neuroblastoma, and skull base metastasis. And meningioma in the olfactory groove will simulate, and this is known as subfrontal meningioma, will simulate any meningioma anywhere. And it's commonly a homogeneously enhanced lesion of intermediate signal in the T1 and T2 weighted image. And sometimes you can see the CSF cleft sign, which is an indication of extra-axial lesion. And I have explained this many times in the lecture of brain tumors. Then this lesion may show matrix calcification and may also lead to reactionary bone sclerosis of the related skull base bones and may also show dural enhancement, which is known as the dural tail. This is a classic appearance of olfactory groove meningioma showing intermediate signal in the T1, T2, and the flare with homogeneous post-contrast enhancement in the classic CSF cleft sign around the tumor. And you know that meningioma, because of the cellularity, will show restricted diffusion and diffusion weighted images. And this is one of the criteria of meningioma and the lymphoma. In diffusion weighted images, they show diffusion restriction because of the cellularity. And it appears iso-intense in the T1 weighted image, iso or hyper-intense in the T2 weighted images, dural tail, restricted diffusion, and the MRS will show the characteristic peak of alanine, as I have mentioned in the lecture of MR spectroscopy. Then perilesional edema is variable around the meningioma and is not a landmark for aggressiveness. And calcium may be present in the meningioma, but better seen by CT since MRI is not so much sensitive to the presence of calcium. Homogeneous contrast enhancement, cystic component of the meningioma is well known finding in what's known as cystic meningioma. Finally, we came to the metastasis. Metastases affect any part of the head and the neck and any part of the skull base. Then the diagnosis is usually depends on the clinical history of a known primary malignancy. But in this patient, there is severe pain and progressive proptosis. The MRI showed a destructive lesion in the lateral aspect of the orbital roof as well as the adjacent part of the frontal bone. Then they thought that this lesion is a primary lacrimal gland carcinoma, and after surgery, they found that this tumor is a metastatic deposit from a small lung cancer that was obscured by pulmonary fibrosis. And this patient got some enhancement of the dura and enhancement of the optic nerve. Then this was thought to be a meningioma of the clinoid as well as the optic nerve. This patient is known to have breast cancer, and the surgical biopsy confirmed that this is a metastatic deposit from the breast carcinoma. And this patient is known to have metastatic mesenchymal chondrosarcoma presented by progressive optic neuropathy. The CT scan preoperative showed a destructive mass in the greater wing of the sphenoid as well as the lateral orbital wall with significant extraosseous soft tissue component encroaching on the orbital cavity. Then this MRI is obtained after surgery with removal of the metastatic deposit and improvement of the visual acuity. Thank you very much. Alhamdulillah Rabbil Alamin.